All right, we will get started. Again, I'm Lisa Towers, Director of Marketing for Lumina Health Partners. Today, our webinar is CMS's MSSP final rule changes, I'm sorry, I can't see the title, how ACOs share in savings and take on risk. Just a couple of housekeeping items. Our webinar will run about 30 minutes, and then we'll have 15 minutes of Q&A. Everyone is muted during the webinar, but you can use the chat feature at any time. If you would like to submit a question, you can use the Q&A box in the Zoom control panel. You can ask questions at any time. You don't have to wait till the end, but we will have a Q&A session at the end of the presentation. The presentation will be emailed to all participants at the end of our webinar, so it should be sometime this afternoon that you'll receive an email. There'll also be a survey link in there, so if you could take the survey, that would be wonderful, and just give us some feedback on how we did today. And then we will also have a webinar next month, or I'm sorry, at the end of February. It's ACC's A Key to Value-Based Payments on February 21st. We hope you can join us for that as well. We are Lumina Health Partners. We're your partner on the journey to value. Lumina Health Partners recognize industry leaders work hand in hand with clients to guide healthcare organizations as they optimize the performance of programs to meet the demands of an increasingly value-based care payment environment. Our advisory services are here: value-based strategy, digital innovation and analytics, clinical transformation, and leadership and governance. And today, our webinar topic falls under value-based strategy. Today's presenters are Linda Michelle, Managing Principal, John Malone, Principal, and Doug Ardoin. And I will turn it over to John to start our webinar.
Good afternoon, everyone. My name is John Malone. I'm a Principal with Lumina Health Partners, and I'm going to cover an overview of the new Pathways to Success final rule. We'll cover some of the details in the basic program and the enhanced program. And after a few slides on that, I'll turn it over to my colleague, Linda Michelle, who will cover strategies for operating successfully in the new Pathways to Success program. And she'll turn it over to our colleague, Dr. Doug Ardoin, who will cover some information around provider engagement and network considerations, as well as identifying some approaches to risk and risk mitigation. Okay, next slide, please. So let's jump into an overview of the program. Basically, it has 5 levels, levels A through E in the basic track, and there's an enhanced track. In the chart on the side there, you can see how the current MSSP tracks map into the new structure. So levels A and B are upside only, and levels C through E in the enhanced track are two-sided with progressively widening risk corridors. In other words, as you move through the program, the amount of upside savings potential increases, and the amount of risk that you could be at a loss for increases, and so that gap widens, the corridor widens. The next question then is, what track will I end up in? What part of the program will I end up in as I move into it? And in order to answer that, you have to know what your experience is with risk and what your revenue level is. So if in the past you were part of track 2, track 3, track 1 plus, the Pioneer ACO model, the next generation ACO model, the ESRD care model, any of those would mean that you have experience with risk. And so that answers the first question. The second one then is, what's our revenue level? Are we a high revenue or low revenue ACO? And to answer that, you have to know your percentage of total Medicare Part A and B revenue compared to your total expenditures for your assigned beneficiaries. If you're 30% or 35% or higher, then you're a high revenue ACO. If you're lower, then you're a low revenue ACO. So basically it's revenue high, low, risk experience, yes, no. And that's kind of the framework. We have a flow chart we'll show you in a couple minutes about how to kind of walk your way through that so you'll know where you would end up. In the basic track, once the new program level is entered, ACOs progress annually to the next level. And the agreement periods have been increased from 3 years to 5 years. So ACOs in the basic track cannot progress to the enhanced track until the beginning of the next agreement period. And interesting to note, ACOs whose contracts did not expire in December of 2018 will have the opportunity to finish out their current agreements. So in effect, there will be two programs running concurrently in 2019 and 2020. So that's a quick high-level overview of the new program. Next slide, please, Lisa. So let's dig into some of the shared savings and downside risk calculations and percentages. So on the top side of this chart, we have the shared savings. Level A and level B allow you to share in 40% of the savings, not to exceed 10% of an updated benchmark. Now, of course, the benchmark is your total costs for your assigned beneficiaries. It's based on that total cost. And so if you're doing better than the benchmark, you can share in savings, assuming you meet certain quality performance levels. And you'll split that in level A and level B 60-40 with CMS, you getting to keep 40%. Then as you progress through C through E, that jumps up to a 50% split with CMS, depending on quality performance. And it continues to be not to exceed 10% of the updated benchmark amount. Then in the enhanced track, up to 75% sharing rate, so you get to keep 3/4. So on the downside risk, it progresses with level D. It remains at first dollar losses at 30%, but it jumps up to 4% and 2% of benchmark. And then it jumps to 8% of revenue capped at 4% of benchmark in level E, all the way up to somewhere between 40 and 75% in the enhanced track, not to exceed 15% of the benchmark. So as you progress through the levels and into the enhanced track, that risk corridor widens. The upside continues to grow and the downside risk continues to grow as well. Okay, next slide, please. This is the flow chart that helps you understand where you would begin the program. So remember that earlier we said it's revenue, high or low, and experience with risk, yes or no. So let's go through the high side of this chart, moving over to the right on the high side. And then with risk experience, if your experience is yes, you're in one of those earlier programs, you go right into the enhanced track of the new program. Doesn't matter if you're a new ACO, reentering or renewing, you go right into that enhanced track. But if your risk experience is no, then you start off in level A if you're a new ACO, or level B if you're reentering or a renewing ACO. Now on the other half of the chart, if your revenue is low, but your risk experience is good, or you have risk experience, then you move right into level E. Whether you're new, reentering, or renewing, you jump right into level E of the program. And if your risk experience is no, you're a new ACO, you go right into level A. If you're reentering or renewing, you go into level B. So in effect, depending on your revenue and your risk experience, you can end up in many different places in the program initially. And the only one here that isn't, the only place you can't start is level C, as it turns out. Okay, next slide, please. A few other additional changes that are very important that we wanted to highlight here before I turn it over to Linda. On the assignment methodology changes, ACOs can now choose between prospective or retrospective assignment and can change their elections annually. That's very important because it gives you an opportunity to take advantage of information as it comes through year to year.
Also, what's included on this slide is the HCC risk score adjustment. So there can be some movement in the HCC risk score over the contract period of time. And it can actually go up, but CMS is going to cap that at 3%. So they're not going to let it go up any higher than 3%. So as it states here, you could do a great job of capturing HCCs and documenting, but they're going to cap how high your risk score can go. Unfortunately, though, they don't put any caps on how low it can go. And so if you're not doing a very good job of documenting, et cetera, and capturing HCCs, that can be a problem. John, do you want to take over at regional benchmarking?
Yeah, thanks, Doug. And sorry to everyone about these problems we're having with our connection. Regional benchmarking, this is important. The percentage of the benchmark that's based on your regional competitors is going to increase all the way up to 50% in year 4, which will be very important for those in highly competitive markets. They're also changing the SNF 3-day waiver and the telehealth programs to enable more efficient care, which should be an advantage for everyone. And finally, they're introducing a new beneficiary incentive program where you can provide beneficiaries an incentive payment of up to $20 for each qualifying primary care service. And this is a way to get some of the higher risk patients into the office. So that's a summary of all the changes. Again, I apologize for those connection issues. And with that, I'm going to turn it over to my colleague, Linda. Over to you, Linda.
Thanks, John. Lisa, can you advance the slide? Thank you all again for joining us this afternoon. And John, thank you for that great overview of the new Pathways to Success program. We're going to talk about, for the next few minutes, about some strategies for success in the new risk-bearing program with Medicare. For many of you who are already participating in an ACO organization structure on upside only, you have developed some strategies to enhance your performance on the upsides of your contract. We are going to recommend that as you begin to move toward risk, that you think about some alternative strategies, enhancing strategies that you may already be doing, and evaluating those strategies to formalize some of them in incentive programs and shared risk programs, so that as you are bearing risk moving forward, that you have a hold of how much of that risk you are going to be responsible for versus other members of your network. Of course, you always want to think about where you are in relationship to the Medicare waiver program and discuss any risk that you might share with your Medicare representative. Some of the strategies that we think are really important as we think about managing our shared up and downside risk, assuring that your physicians in your network understand how to drive results, are managing the patient and beneficiary population by data that you can provide. Doug is going to talk more about choosing participants and making sure that your providers are really prepared to manage risk in your beneficiary structure. Ultimately, also making sure that the data systems that you have available to you can really account for total cost of care, and that you are sharing that data in a transparent way across your provider network, and really have an understanding of how that data works. And finally, developing high-level financial analyses on a relatively real-time basis, so that your entire network of participants understands where you are against the benchmark and risk of your contract. Managing leakage in your ACO contract is more complex than in many of what may be other commercial contracts that you participate in that have narrow networks or limit the ability to choose out-of-network providers to a patient population. Of course, the fee-for-service Medicare population has a wide range of choices for providers in the specialty network and hospital network. And so as you are bearing more risk in these contracts, it's going to be essential that your organization begin to understand how to manage the movement of your patients across the network, even given their ability to choose. So one of the things that we are recommending is that every ACO participant, as you enter risk, really begin to evaluate the value of your preferred specialty network and develop a high value network, meaning that you need to have metrics in place to really understand the performance of all of the participants in your network from hospitals to ambulatory care services to specialists. We think in order to manage care that you need a full range of services in your network, including ambulatory services and post-acute services. This may also include palliative care and home care and hospice. Of course, these kinds of services are complex in getting patients to use this level of service on an ambulatory in an ambulatory setting, but we find that very high quality networks use these services extremely successfully and increase the quality of care to their beneficiaries. So really important to think about. Finally, well, you want to begin to think about what kinds of technologies and protocol management are available to you with either the technologies you have now or identifying technologies that are currently in the market. We have seen some really pretty good new systems in the market that help bidirectional communication between primary care physicians and specialists, help primary care physicians manage patients into the high value network, encourage specialty providers to look at that data, understand what the primary care physician is asking the specialist to do or the specialty organization to do, and really get that information back to the primary care doctor in a timely way so that beneficiary's overall quality of care can be managed across the network. Finally, you want to think about developing protocols that all your organizations are willing to participate in when deciding whether a patient should be in an ambulatory setting or an inpatient setting. Next slide, please. The other part of this, and many of you in your upside ACO contract are not yet sharing incentives with other providers in your network. But as you get into full risk contracting, we think it's a good time for you to think about the opportunity to align incentives, which means sharing some incentives with specialists, hospitals, post-acute organizations, but also developing structures in which you might share some of the risk for the total cost of care in that population. We think that it's really important to understand and have your primary care doctors work across the network to develop very specific programs for patient populations in specific disease sites so that you have a best practice for your region and for your patient population in order to get them the highest quality care and manage them to in the appropriate site of service so that we're always managing the population and beginning to change the cost curve so that your network performs in a really high quality, low cost way. Finally, we want you to think about making sure that you have appropriate capital reserves in place in the case that you do have a negative performance year so that it doesn't affect your long-term ability to continue to participate in the program. I'm going to turn it over to Doug to talk more specifically about how to engage and manage physicians in the new risk-bearing programs. Thanks. Thanks, Doug.
All right. Thank you, Linda. And I appreciate that. So yes, my name is Doug Ardwan, and I am managing principal with Lumina. So I've got a few slides here. We're going to talk a little bit about engaging physicians and a couple of other issues that I think are important, whether you are just starting out your ACO renewing or looking to move into some of the different tracks that will be available in Pathways to Success. So first of all, I think choosing a medical director, you really need to think about attitude, someone who's open and honest and a good communicator, a lot of emotional intelligence. I think this is very important because I do believe you can train for this skill. You know, the information that comes from Medicare is pretty straightforward. And it's not going to be a whole lot different in how your medical director will try to manage performance with the other providers in the network. It's going to be a lot around making sure that you're hitting your quality metrics and are paying close attention to utilization and cost opportunities. So attitude and choose for attitude, train for skill. I think that's a great strategy when you're thinking for your medical director. Also, when it comes to engaging with your physicians, you have to be very transparent regarding your data sources. Now, your data source here is CMS, and they're providing you almost all of the information. But how you crunch the data, how you present it is going to be very important. And I think getting input from your physicians so that it's easy to understand and points them in the right direction to be effective is a great way to engage with your doctors. You know, when you begin to think about your performance improvement committee, it has to be professionally managed. You have to have the information coming into into the organization so that you can execute on performance. But it has to be physician-led. And a wise person once told me that physicians like to be involved in and like to create the solutions because, after all, it is what they do for a living. And physicians like data, and they will be critical of data because, after all, they are scientists. So I think it's important to make sure that you engage your physicians in this process. And also focus on big problems first. I think that at times there's a temptation to start looking at things like, well, who's overutilizing or who's not doing this or who's not doing that, versus bigger questions like, are we structurally set up for success? In other words, what do we do to make sure there's access to after hours clinic time and urgent care time during the week and on weekends so that our patients don't feel like they have to go to the emergency room if they have a problem? So I think this is a very important point when you're engaging your physicians in the beginning is let's focus on the big problems first and solve those. Next slide. Now, when you're thinking about choosing providers, I would think it's very important that everybody understand how CMS assigns beneficiaries, and they assign them based on plurality of care. And the reason that this is important is because, you know, in the first step, CMS is going to look to see if a beneficiary has had a PCP visit or an APP visit within the last year, and that's how they're going to assign that beneficiary to a provider in your ACO. But if there has not been a visit with a PCP or an APP, and you can see the specialties that they're looking at, then they may assign a beneficiary to a specialist that's in your ACO. Now, there's a list of specialists that we're not going to go through today. It's a long list, so some are included, some are not. But what's important about this is that some of these specialists have extremely complex patients that have multiple comorbidities, and because of this, you know, it can have a pretty significant impact over the year on the cost of care for that individual. So we may talk later a little bit about how some organizations, multi-specialty groups, et cetera, have even contemplated splitting up their tax ID number, putting PCPs into a tax ID number, specialists into other, and using that in a way to potentially contract within the ACO program. So, but we're not going to spend a lot of time getting into that, but it's interesting what organizations across the country are doing. Clearly, when you choose providers, you have to think about how you're going to manage quality and utilization throughout the year. I'm aware of organizations that at the end of the year, at the beginning of the next year, when they're doing their annual quality audit, some of the physicians would not allow them to come in and do the necessary chart review through the EMR or what have you. So I think it's important up front to make sure that as you're working with these providers that they clearly understand the rules of the road, what's going to be expected of them through the network participation agreement and the contract they sign, that they agree they're going to participate in the quality audit, do annual wellness visits, and that they're open to performance management, because this is going to be real important. And then lastly, when you think about providers, there are issues around care coordination as well. I'm not aware of a single market that doesn't have providers on a multitude of EMRs, and sometimes it's going to be difficult to manage. There are ways within the program to possibly encourage some of the providers to all come together on maybe 1 or 2 EMRs that make it a lot easier to share information, do performance management and care coordination. But this is important because it also feeds into the ability to do seamless care management, because you're going to want to do care management on the rising risk and the high risk patients in your population in order to, you know, keep them out of the emergency department unnecessarily, to hopefully reduce readmissions and keep them comfortable at home. Also, you want to have insight into post-acute care, and this can also be an issue that you want to consider when you are looking at how you're going to do care coordination. Next slide. And so a lot of ways to manage your program using data. I think more traditionally, you know, organizations have used their proxy data or their historical data. And I think it's important to have all that information because it gives you a retrospective view. You can see patterns, see what's going on around utilization and quality. You can also do some prospective analysis to maybe run some type of prospective analysis on who might be at risk for ED utilization in the future, et cetera. But a lot of organizations are also coupling that with actuarial type of data and analysis so that they can have a better understanding of the risk of their population, similar to how insurance companies do actuarial analysis, which can give you some insights into, do you have the appropriate risk score for your population, and other areas you may want to focus when you are thinking about how to manage in future performance. Transparency goes without saying it. You want to make sure that all of your information is officially sourced and tested for accuracy. Developing data-driven reports to help manage the total cost of care is important. And these are from the information you get from Medicare, there's a lot of different ways to look at that information and to create the types of reports that can help you be the most successful. And I think lastly, this commitment and ability to evaluate your HCC coding. There are programs out there that will enable you from a technological standpoint to provide notifications on an annual basis regarding your population, so that you know each year who has to have their codes re-entered. I think we all know that just because you had a chronic disease one year, for some reason the next year CMS may tend to forget about it, so you have to redocument this, but that's fine. There's information and programs out there that can help you do that, and can prompt you, as well as try to build this type of documentation into your annual wellness visit program. I think this is important. It's a way to engage with these beneficiaries anyway on an annual basis and make sure that you're addressing all of their healthcare needs. Next slide. And lastly, just wanted to share a little bit of a high-level financial analysis for those of you who may be first getting into the program. This is just a real quick back of the napkin looking at a basic track A, and a way to begin to understand what your opportunity may be once you begin to receive information from CMS. This was modeled on a ACO that has roughly 20,000 beneficiaries with a per beneficiary per year average spend of about $10,000. So when you multiply that out, that's a $200 million benchmark. You may have received at the beginning of the year that your minimum savings rate has to be 2.5% in order to get first dollar savings and shared savings. As you know, in track A, your share rate is 40%. But all of this, your final take home or shared savings will be impacted by your quality score. What we modeled here is a quality score based on 95%, but typically for beginning ACOs for that first year, all of your quality is based on reporting and not performing. So if you report everything you're supposed to CMS, you'll receive a score of 100%. But let's say something wasn't exactly right, you got 95%. And you actually had a good year. You had an actual savings rate of 3%. So you did better than the 2.5% that was set for you. you know that your maximum share rate is 10% or roughly $20 million. And after it's all said and done, historically there's been a little bit of a holdback by the government of 2% due to sequestration. So on the right-hand side of the slide, there's the quick calculation of $200 million times the 3% actual savings that you achieved is $6 million, times the 40%, which is your share, which is 2.4, times your quality score, which is 95%, 2.28, and then a 2% holdback on that by the federal government of 2.23. So that could possibly be what you actually get. Now, we have at Lumina, we have colleagues and capabilities that can really dig deep into this for you and help get you more accurate analysis on this. Also, we can help take a look at the downside portion of it too. As you probably remember from the previous slide, that gets to be pretty complicated depending on which track you're in and how there are more moving parts in calculating the downside, but we can certainly help you with that. And just an overall ACO risk analysis is going to be very important because it can help you develop the right action plan moving forward throughout the year. Start to think about the mitigating strategies if you are in a dual side track in order to prevent any, or mitigate your downside risk and get better prepared. So these are capabilities we have at Lumina. Even if you're brand new, there's a wealth of information in the macro program through the MIPS reporting, a lot of data available there for both cost and quality that can help to build out a model for you to understand where your risks are and what your opportunities are. So Lisa, that is, I believe, my last slide, and I'm going to turn it back over.
Thank you so much. Did anyone want to run through our summary?
I'm happy to do so.
Okay, great. Thank you.
Okay. So once again, this Pathways to Success, it does offer opportunities for some and then challenges for others. It is important that you got to understand the financial benchmarking methodology because of all the numerous implications. It's very essential to develop a high value network. Really think long and hard about who you want to participate with you, who you plan to ask to join your network, and not just from frontline providers, but specialists as well, and post-acute providers and others that you want to be engaged in success. And so that leads into the next, which is to truly align the incentives across the network for everyone to have that opportunity for positive performance. And it goes without saying, the accurate cost and quality data, transparent reporting will certainly encourage alignment and performance predictability with all of your participants. Okay.
All right, this is our time for Q&A. If you have a question, please submit it using the Q&A tool in your toolbar. We'll answer the questions as they come in. John, I think this is a good question for you. What are the pros and cons of selecting prospective versus retrospective beneficiary assignments?
Thanks, Lisa. That's a great question. At a very high level, the prospective beneficiary assignment allows you to know in advance who your beneficiaries are, which allows you to create registries and helps you identify high-risk patients that that you have to manage throughout the coming year. On the other hand, the retrospective assignment will help with making sure that you're accurate. You accurately understand who your beneficiaries were at the end of the year, and makes for a more accurate final analysis, perhaps.
Great. And can one of the panelists explain MIPS obligations for an independent physician based on the track?
Lisa, say that again, the MIPS obligation?
Yeah, explain MIPS obligations for an independent physician based on the track. Okay.
So traditionally, when you've been in the ACO program, if you're not taking downside risk, then you're considered a MIPS APM. And once you get to downside risk, if you hit the certain thresholds that CMS has created for becoming an advanced APM, then you qualify as an advanced APM. For physicians that are part of your ACO, that are in your network, that are listed as participants, their individual reporting actually now flows through the ACO, and that's how it's been done historically. So doctors don't have to report individually quality measures and some of the other aspects of MACRA and MIPS. So in a sense, it relieves them of that burden, and the burden then shifts over to the ACO. This is how this has been done historically.
Great. And then how do you go about finding a referral management technology solution? Does anyone want to address that one?
Sure. There are several new technologies available in the market that are overlays, much like your population health overlay, if you're using one, that can load and manage a high value network for your primary care providers to use, as well as provide bidirectional information back and forth. If you're interested in finding these networks, we can certainly help you. There are also some technologies available, or you can find them, through ACO and clinically integrated network organizations as well. But happy to help identify or give you some names and contact information if you'd like it. Just let me know and I'll give you that information.
Great. And so Linda, this is another question for you. Will CMS be making any changes to the waiver program to promote better care coordination amongst providers?
So to date, we have not heard that there are changes in the waiver program coming for Pathways to Success. But we would recommend that if you're going to make incentive changes and add people to an incentive program in your network, that you make sure with your Medicare representative that you notify them and that they approve that incentive program in your current contract as well. We'll see what happens as the Pathway Success program continues and see how successful people are. But most Medicare representatives are encouraging relationships that include incentives.
And then this is for the whole panel. Can our ACO apply for a basic track E for all 5 years?
So the program is designed for you to increase the level of risk that you bear over time. That's how the program is designed. So I could
answer that, Linda.
Yeah, go ahead, John.
I was just going to say, if you're a high revenue ACO and you have experience with risk, then you will then you'll be an enhanced. So you'll skip right by that. But if you're a low revenue ACO with experience with risk, then you'll move right into E. So it really depends on what your past experience was. It's my understanding that CMS does not want people taking on more downside risk than they've had experience with in the past as they enter this program.
Thank you. And then a question for Doug, I'm sorry. Are multi-specialty groups creating PCP-only TINs for purposes of the MSSP program?
Yes. There is some organizations across the country that have done this, and it is a strategy when thinking about the attribution of beneficiaries to your ACO and how you want to move forward, with kind of the level of either risk or highly complex patients within your ACO. in general, I think for most multi-specialty groups, the large majority of those patients that would be attributed to you are going to be attributed to your PCPs anyway. So yeah, this is a strategy that some organizations across the country have thought of and are implementing.
Great, and I think that's all the questions we have for now.
There was one question, Lisa. I'm looking at from the chat about, can you discuss the variable methods for flow of funds to distribute gain sharing dollars? And I can tell you that for the person who asked this, whatever you decide your methodology is, as you probably know, you have to post this on your website. So Medicare does have rules about being very clear about what your distribution methodology is. Now, depending on how your ACO is set up, there are many different ways that you might want to approach this. I think a lot of organizations try to cover the costs first. So if there is a distribution or a gain share from shared savings at the end of the year, they will look back and see, what the expenses for running the ACO were. Clearly, the labor, the supplies, et cetera, and we'll want to cover that first. Then once that's covered, once that cost is covered, there may or may not be a small percentage then distribution above that to the sponsoring organizations, and then the rest of the distribution would go to the actual providers and participants. I've seen a lot of organizations try to definitely want to weigh this more toward their primary care providers, since they are shouldering most of the responsibility for driving quality and performance in their ACO. So there's a lot of great examples out there. A lot of the successful ACOs, like I said, everyone posts this on their website. I think there are a lot of great examples. And this is also something that we can help any new ACO kind of think through and work through in order to make sure that you do create a very fair and equitable distribution methodology.
Great, and thank you to our panelists for all this great information. And thank you for joining us today. If you want to learn more about Lumina Health Partners, you can go to our website, luminahp.com. You can follow us on Twitter at luminahp. We also have a LinkedIn company page that you can follow us on, and also a YouTube channel. And this is the contact information for our presenters today. Again, we thank you for joining us. We hope to see you on future webinars. Have a good afternoon.